Here, down here. This one? Yes.
Okay.
Okay.
So we. So,
Everyone is able to hear us?
This is not working.
Can you guys hear us?
Yes.
Yes, we can.
Yes.
We did that. All right. So we talked about subdural common. I mean, with less instrumentation, so you see less, but can happen. Cerebellar hemorrhages, preterm greater than full term uncommon. You don't see it that often. May have symptoms of brainstem compression, respiratory irregularities, lateral eye deviation. You can do a head sonar or long-term developmental issues. All right, so periventricular, intraventricular hemorrhages, periventricular bleeding into the subepidermal germinal matrix, right, and IVH bleeding ruptured into the ventricle system. The germinal matrix, again, it's a highly cellular region that is highly gelatinous and richly vascularized, right? And it goes from anywhere from 26 to 26 to 34 weeks that it's in that area. I mean, of course, the lower the gestational age, the higher incidence of bleeds.
This meeting is being recorded.
All right. Okay. All right. So, and then when you get close to term, of course, it evolutes. All right, and less likely to have a term baby bleed or have intraventricular hemorrhage. All right. So yes, preterm, greater than full term epidemiology, less than, like you see here, like I said, the weight, of course, has to go with the gestational age. The lower the gestational weight or gestational age, the higher incidence of bleed. All right. Definitely giving the steroids to moms now has decreased the incidence of intraventricular bleed, you know, and even our incidence of shunting. Now that baby got shunted next door, but that baby was a preemie who was infected. So this is not, the normal circumstance for how a baby bleeds in the NICU. Because even a baby who's premature, that 500, 600 grandma that goes through the NICU, our incidence has gone down overall in terms of bleeds, and severe bleeds is definitely down, right? Again, like I told you, it's the area is very fragile, right? It has poor support, so all right, and the way the vessels turn it increases the pressure in the area, okay. And I see this is just a picture of where you see the bleed here, okay. So most of the bleeds will occur in the first 24 hours of life, you see. So anything that we do to change cerebral blood flow can cause a bleed, all right? Intubation, all right? Pushing excessive fluid, hypotensive, the way the baby was, why was the baby delivered, was mom abrupting, things like that. So anything that's going to throw off cerebral blood flow or change cerebral blood flow is going to increase the incidence of bleed. So the problem, that's why it's been an issue now in neonatology with us. One is, of course, teaching, right? With the residents, you want to teach, but, how many times are you going to try with a 20-something weeker to intubate, all right? So it becomes a little bit of a dilemma. It's been over the last, I would say, 10 years now or more. When I was a resident here, we did everything, right? Because we spent so much time in the NICU. We didn't even call the neonatologists to come down for the 20-something weekends, 27, 28 weekends, all right? At nighttime, even Dr. Harron wouldn't even come in afterwards, all right? We would manage. He'd tell us over the phone, blah, 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 and we would do. I left for fellowship, and when I left in '94 for fellowship, when I came down, the ACGME switched things around, and that's why when I worked with the PAs only did the feeders and growers. By the time I came back in '97, even though I was covering here at night during my whole fellowship, he reversed the roles because you guys spent less and less time in the unit. All right, and it's got down to 2 months, and this is throughout the country. It's not only this program. All right, so it's not that is against you guys. It's just unfortunately this is what ACAG decided. I mean, I had somebody come for a job to cover nights over there, like Dr. Buka and Dr. Acuna, and she came from a big program, and she didn't know how to intubate. She didn't know how to. She didn't know how to intubate. She didn't know how to put IVs in. So overall, in this program, you're still getting hands-on in terms of dealing with, and of course, if you want more, you let us know, and you'll get more. All right, but the days of coming after you for doing things it's gone. You guys have to show an interest because it's difficult, this baby's life. I can't have people practicing on a 20-something weeker, right? If they're not going to put the time in and get a little bit with the intubation, all right? So, and then 90% occur within the first 72 hours. So you see the 72 hours correlates to the sickest time of the baby's life, right? So already the fact that the baby's so sick, the risk is very high for bleeds, right? Ultrasound, usually we used to do early ultrasounds. The only reason I'll do an early ultrasound now is if it's a extremely low birth weight baby, a 23-weeker, 24-weeker, and the baby is very sick. And the ultrasound may help in terms of if there's a significant bleed and the baby is decompensating, maybe to withdraw care. And we call it futility care, and let the parents know that the outcome is not going to be good. So withdraw the care and let the baby expire. That's the only reason why I would do an early sonogram, because doing it early, it's not going to make a difference in terms of management. All right. So management, keep the BP from fluctuating, avoid volume trauma, like I said, mechanical ventilation, monitor for it's just a matter of constant monitoring of when the issue is how do we recreate in utero life when the baby is born, right? So decrease the external stimulation, decrease the amount of touching, procedures done, things like that, right? 2% of full-term infants may have it, and 40% have severe neurological sequelae. Right. So most common intracranial hemorrhage, and going back to it, of course, this is the most common intracranial hemorrhage in premature infants. Like I said, with the percentage, the earlier, the higher percentage. We talked about that. Talked about the cerebral blood flow changes, right? And if you think about anything that we do, drawing blood on these kids, the ventilator, intubation, fluid, too much stimulation, could all change cerebral blood flow. All right. Already they have a deficiency. They're premature, so they're going to have deficiencies in their factors, right? So they're prone to coagulation disturbances, right? You see how many next to platelets. All right. Told me about that. Talked about that. All right. So what I was talking about here is that the turn, right? You see the way the vessels are, okay, and tortuous, and it increases the pressure, and it's a good setup for a bleed. In other words, I mean, that area was created to allow cells to go into the brain and develop the brain, right? So that's why you needed that structure to be semi-permeable, so the cells can go out and the brain can develop. All right. So it wasn't meant to be, and it was meant to be in a enclosed environment. So you weren't meant to be born at that age, right? So of course, when we pushed the envelope and like I told you, when I was a resident, 27, 28 weeks was difficult. Now it's not a big deal. You know, bleeds are extremely uncommon unless there was a traumatic, something at birth, right? Or big culprit in the NICU is a pneumothorax, all right? Especially with a 1,200 gram kid or a preemie, definitely a little less than a kg kid, almost definitely you're going to have some sort of bleed if it's not diagnosed promptly. Okay, so we grade them, right? So grade 1 bleed occurs just in the germinal matrix. That's the majority of the bleeds. 2, bleeding occurs inside the ventricles. The difference between 2 and 3, there's the ventricular system starts to enlarge in grade 3, all right? So if you had a baseline, then you could tell if there was enlarged. Sometimes you can't tell, so radiologists may call a 2 or 3, a 3 or 2 initially, until he sees another comparison and then sees the ventricles. A grade 4, okay, so you can go from a 2 to a 3 because the blood's in the ventricles, and whether or not it starts to the blood breaking down the blood blocks the regular villi, prevents reabsorption, then you get your hydrocephalus. But you don't go from a 3 to a 4. So a 4 is an event. A 4 is an event that already affected brain tissue. Okay, and parents ask, okay, what does this all mean? No matter what, something happened to cause the baby to, even though the incidence of developmental issues are very low at a grade 1, but there was an event that was abnormal that caused something to go on in the brain. So of course the baby's at risk, all right? Depending how significant the event is, then you can say the grade, all right? So grade 4, there is already hypoxia to the tissue, okay? Plus, you may see the blood in the ventricle, all right? So you don't go from a 3 to a 4. It was a separate event, all right? So you see the hemorrhage here, all right? I mean, sonogram is repetition, right? Like anything else, you have to read it. Dr. Parab did it back in England, so they used to do their own sonogram, so he's pretty good at reading them, right? And, when you read a sonogram, the only way to really get good at reading sonograms is doing sonograms. Because then you know the way the probe is, what it means, how to, when you adjust the probe. Same thing with echo, right? When Dr. LaCourte's telling you what it is, all right? So grade 1, you see here's only in the germinal matrix, right? Okay. So grade 2, there's some blood in the ventricles, right? You see here. Again, you wouldn't know if the ventricles were dilated because unless you had a previous one, right? This is grade 2. Right, and then 3, you can see how the ventricles from the previous one, right, getting larger, right? So then, if it was the same patient, you say this was the first sonogram we did, and then all of a sudden you repeat it, you see it's grade, if there increases, it was a grade 3, he would call it, right? Okay, but, right. This is later on, 2 weeks later, venous infarction may develop into the hypoechoic areas, right? Cyst formation. Now we have babies that are born with cysts. You know what I mean? So they may have an event in utero. That's what you tell, when I do newborn, when we cover newborn, the parents should say, "Oh, is everything okay?" So, and my words would say, "For now, everything's okay." So some parents would catch, "What do you mean for now?" I said, "Well," then I would go into it. The ones that didn't ask me, I didn't go into it because the assumption that everything is fine, right? But we all have defects, right? Okay, or we will always be able to hit baseball like Derek Jeter or basketball like Michael Jordan, and then be Einsteins. So we all have some problems, and that's how I explain it to parents that we all have defects, all right? And you don't know if the baby had an insult in utero. So as a parent, I tell them, simple as possible. Unfortunately, you worry for the rest of your life. So you worry the baby's going to roll over. As they roll over, you say ah. As they sit, you say ah. As they stand, you say ah. As they start to talk, you say ah. As they go in school, they say ah, and they're doing well. You say okay. And of course, the other issues come, teenage. But it's a never ending. So you don't know if there was a insult. All right. And that's why you can sue up until they have to sue a certain amount of period, but you can sue up until 20 kids, right? So PVL is periventricular malacia. All right. The problem with us now is, we have a very low incidence, but is it low incidence because the radiologist is not reading it properly? So this occurs. So when we get very concerned when we ventilate these kids, and if we ventilate them too much, PCO falls below 30 on the gases, it's a forerunner for PVL, right? Of course, any ischemia, hypotension, like I said, homeostasis, right? So these kids can get ischemia, and then later on you see the defects, and then they'll form cyst formation later on, all right? Now, the problem is long term, what does it mean, right? Motor delay. So it's hard to give a good prognosis with these parents. Even with a grade 4, you can't be all doom and gloom. You give them a little hope, but you definitely tell them that there's a high risk for cerebral palsy. All right. So PVL mostly less than 32 weeks outcome. Usually lower extremely more than upper. Right. Findings are not evident earlier than 1 month of life. All right. And so an MRI 6 months down the road is more indicative of, all right, there's less water in the brain. Every time we do an MRI early on in life, the radiologists will read and say, oh, it could be normal because of the myelination is decreased in the newborn. There's increased amount of fluid. So it's never a good test MRI. The only time MRI helps if there is we have that baby downstairs there where there's something grossly wrong that you can tell there's something's grossly wrong. But subtle things you may miss in the newborn. So you may call it a normal, but I always tell the parents 6 months down the road, if the baby developmentally is not doing well, then get an MRI, right? All right. So, like I said to you, it's not an extension of a grade 3, right? Grade 4, but there's some parenchymal damage. All right. So you see here, it's adjacent to the ventricle, and there's some damage. So you can get with the grade 4, you can get porencephalic cysts later on. Okay. All right. So grade 1 to 2 bleeds generally have a good prognosis. Grade 3 to 4 bleeds have a variable long-term deficits, right? Both outcome in the grade 3 hemorrhages is usually good when no parenchymal injury. So when we start seeing PVL, you could all bets are off. You can pretty much tell the parents that there's going to be some sort of long-term disability. All right, and you can see oops. You can see the cyst formation. See? All right. So we have kids that the less than the kg kids are coming to the unit and sick. You can't ventilate them, extremely acidotic, right? And have these major events that they go through. So it's almost like a CNS-induced lung injury. They have massive bleeds, right? It's rapid, right? Minutes to hours, neurologic deterioration. They don't seize. The brain, of course, is immature, so they don't propagate seizures like a full-term baby may do, right? You may get posturing. The pupils may not be helpful because already depends how premature they are. But of course, if there's blood in the ventricles, the fontanelles may bulge within a day. Okay. Big thing for us is the hematocrit, right? Right, the hematocrit drops precipitously, right? So where the hell did the blood go? Went into the ventricles. All right. I mean, we draw blood, but of course, they can have temperature instability. And again, very difficult when they have these massive bleeds, catastrophic bleeds. It's very difficult to ventilate them. All right, and those are the ones that if it's going on and is high risk for bleed, I would do the sonogram if you're seeing it. If the baby's decompensating, then make a decision whether or not just let the baby go. Especially if it's 500 grams, 400 grams, the outcome's going to be poor anyway. So, solitary, these are more subtle, on again, off again. The baby's in the unit, having apnea here and there, and then hypotonia. You go and end up doing a sonogram and you see a bleed, all right? But it's just little subtle signs, all right? If you examine them, abnormal tight popliteal angle, right? Is questionable. Is there an injury, irritation? And then of course the clinical silent, right? Baby's course is uneventful. All of a sudden we do the sonogram at 7 days, and we see a damn bleed, and you say, damn, baby didn't even act up, no apnea, nothing. But there's a bleed there, okay? So, hopefully, if it's just a grade 1, the outcome should be good because, there was not much signs, all right? Again, just being premature, so diagnosis is just recognizing, right, that the baby's premature, screening the ultrasounds, right? We don't do LPs, right? We may do LPs later on if there's increased ventricular size to relieve some pressure before they do ventricular taps, right? CTs are very, when the kid's intubated, is not, early on, it's not something that we would do.
The ultrasounds, like you said, if we don't do it because we suspect a bleed, in all the preterms they do it at 7 days after the life.
Yeah, usually we have a guideline at 32 weeks and below. We'll do a sonogram at a week of age.
A week of age. Okay.
Yeah. I've always sonogram is abnormal. What do you tell the parents? Oh, you still gotta wait. We don't know what's gonna be. Okay. Sonogram's normal. What do I tell the parents? Still gotta wait. Don't know if the baby, because this is just a gross picture of the brain. It doesn't tell you how the brain functions. Okay. So in other words, we don't know what we're talking about. Okay. That's a polite way of saying it. Okay. So you give a lot. Unfortunately, in neonatology, you give these mothers a lot of information but no answers. So it's kind of, So again, of course, management, of course, is prevention, right? Prevent premature birth. So they're saying where are all the preemies during COVID time. So, they decrease incidence, right? The mothers are home, not running around, not working. So definitely decreased incidence of prematurity. So it'd be male chauvinist. Should be home when you're pregnant. I'll shut my mouth. But in other words, you want to know why there's an increased incidence because, and why we're not going to get rid of prematurity is because of all this going on, right? Right? And of course, in the delivery room, the management. See, prevent major hemodynamic disturbances, pneumothorax, right? Okay, this acute, like I always said, homeostasis, everything done slowly, correct. Unfortunately, if the kids in a cold situation, it's unavoidable to do things quickly. So management of post-hemorrhagic hydrocephalus caused by obstructive ventricular CSF outflow, impaired CSF absorption by the arachnoid villi. Okay, so you have close surveillance. You have head circumferences. We do like again, once the head circumference gets a point and the ventricles are full, the fontanelle's full. The baby may start having episodes of desaturation. They don't have this typical triad with high blood pressure that you see with increase because the sutures are still open, so the intracranial pressure doesn't increase. You may see some subsetting and things like that, but you don't see all the sequela of increased cerebral pressure. All right. I mean, we've tried osmotic agents. A lot of this stuff doesn't work. So really, there's not much to do except if they're in the unit, you would do serial ventricular taps, or the neurosurgeon would put a reservoir in, right? And then wait till the baby's big enough and then shunt. Again, like I told you, reservoir, right? And you see here, 90% major sequela, again, it's a percentage, right? So you want to give the parents not overwhelming support, but that there is a 10%, I don't talk numbers with them, 10%, 5% nonsense, because it means nothing when you fall into nothing happens. So when something happens, then you talk about it. But there's 10% that even with a grade 4, we had grade 4s and they're fine, right? And that's when we talk about plasticity of the brain, right? That some other area of the brain is taking over. So perinatal asphyxia, right? Arterial cord gas less than 7. They're not going to ask you this on the boards, but it's going to be in the question, so you know that the baby's asphyxiated, right? The APGAR scores are 3 or less, greater than 5 minutes. Evidence of altered neurological. So the big question for them is, you would send this baby for cooling, things like that now. If they were asking questions, if that was one of the answers, what would be one of the therapies, right? So you can get multi-system organ injury, right? So with the brain cooling and the body cooling this was the event. So if you look in Volpe, there's been so many drugs to try to prevent what we call the reperfusion injury. So the baby gets asphyxiated, you get decreased cerebral blood flow, you get necrosis, dead cells in the brain. So what causes the rest of the damage, whatever's dead is dead, but what causes the rest of the damage is that the dead cells release the enzymes into the surrounding tissue. So when you reperfuse the brain, right, that's when the injury starts to happen. So a lot of these drugs that were tried over the years was to try to slow down the process or inhibit the process. Calcium channel blockers, they've done everything. Nothing's worked. Now they do this cooling. Now whether the cooling is working is not working on a true stage 3 Sarnitz classification, stage 3 comatose baby who has multi-system organ damage. It doesn't work. So, of course, everybody spent a lot of money. So let's cool everybody. So now if you look at the incidence and if you look at a stage 1 encephalopathy, the sequela is very low, right? So if you cool that baby and you already have a low sequela, how the hell are you going to differentiate that? But oh, look, cooling's working. Even with a grade 2 and a baby seizes, stage 2 and a baby seizes, right? You still the sequela is not that bad, right? Certain the high percentage are going to be normal, right? That was a famous board question every year. Was baby has this APGAR, right? Was resuscitated in delivery room. The baby starts to feed, day 3 of life, blah blah blah, sucking well, appropriately. What would you tell the mother? Nothing. Everything is just observation. No other further testing right now. Okay, that's the old famous question every year they gave. I don't know if they still do it. All right. So NEC, necrotizing enterocolitis, definition: severe neonatal disease characterized by mucosal and transmucosal necrosis of the intestine, primarily ileum and proximal colon. Right. The older kids will get the colon. The smaller ones will get the ileum. Sporadic, right? That occur periodically, right? Unfortunately, we had one a couple months ago, which was heartbreaking. Kid with total bowel, almost like a vascular accident that the whole bowel got ischemic. Again, there were some units were known for it. All right, they had clusters. They had known in the unit. We start antibiotics on them. A lot of times we don't get positive cultures, so nobody knows the etiology. Of course, why we start antibiotics? Because NEC is going to disrupt the mucosa, right? So when you disrupt the mucosa, you're going to allow the gut flora to go into the bloodstream, right? Make the kid sicker. So whether or not whether or not the chicken before the egg, what came first, right? Varies significantly the incidence, right, from 3 to 20. It depends on the unit. Some units have a high incidence, all right? Some units who deal with a lot of preemies view this as a normal part of neonatology that they don't stress over it, right? Again, IUGR, there's a higher incidence. Why? Because IUGR, same thing with the diving seal reflex. Everything, when the baby's not growing well in utero, the reserve is poor. So everything's diverted for the brain. The brain's got to grow. So you have asymmetric babies who come out, they have normal head circumferences. Meanwhile, they're less than a 10th percentile in terms of growth because the rest of the body did not receive nutrition. So the gut flow is decreased. There's a high incidence of perforations, right? They can get. Doesn't have to be necessarily NEC. So NEC is a disease of the growing preemie. That's what kills us. So you get over this acute part of these kids, and they're growing well, they're feeding, they're off the ventilator, and then all of a sudden, boom, they get necrotizing enterocolitis, right? So our baby there, the twin, even though Dr. Gilchrist said it's NEC, in OR was NEC, it's not NEC. That was a solitary perforation. Okay, it was too early. Couldn't be. It's not NEC. Too early on in gestation. So that kid, both of them were septic. So that was a solitary perforation. It's not NEC.
The King Pan?
Yeah, it's not NEC.
Washington was.
I wasn't going to argue with him in terms of that, but so you see here, 26 weeker, right? 3 weeks later, highest incidence onset. 31 week, 11 days. Full term, this what kills you. The first 3 days of life. So a full term, who is SGA downstairs newborn nursery, is at high risk, right? That we've had actually the ones that we had before Washington, we had 3 full-term babies that had necrotizing enterocolitis, right? For various reasons. One had E. coli, the other one, mom was having these pseudo seizures, whether or not that was changing blood flow, all right? So, and you see here, male or female is equal. I can move this or no?
Yeah.
Yeah.
Where is it? Every time I touch it, it keeps I'm gonna turn it off. Yeah, what the hell? All right. 5 to 10% of the cases occur in babies born greater than or equal to 37 weeks. The risk factors: asphyxia, EGR, polycythemia, right? Uh, you know when we talked about exchange transfusion? Why? Because if you muck around with the first of all, because of if they're polycythemic, you can throw clots with the GI, but also the umbilical catheterization, right? Remember, the umbilical catheter goes in through the artery. The artery is very small in the diameter, yeah, right? Now you're taking up some of the space with a catheter, so you're changing the flow. The catheters years ago used to be more thrombogenic, but less now. But still, the minute you put the catheter in, the body forms a fibrin sheet over the catheter. All right, so definitely, all right. So that's why a lot of places do not keep umbilical catheters in more than 3 days. All right, we tend to do it longer. There's other reasons why I do it here, because of the decreased the amount of manipulation on these little ones. We've gotten away with it. Then again, it's something to think about. Of course, gastroschisis, the bowels are all out, so they're more prone. Right? Congenital heart disease and meningomalcesis. I told you this. All right. You can see the incidence is higher in the lower gestation. As you get older, the incidence decreases. All right. Despite significant advances in neonatology, mortality resulting from NEC is not improved over the last 3 decades, right? So, right now, if a kid PG blows something or looks like NEC, I would say 90% of the units now, all the surgeons that are trained, the pediatric surgeons, are just going to put a drain and sit and wait, and hopefully it'll get walled off, and then later on recanalize, and then see if the baby would feed. If he doesn't feed, once things quiet down, you can't feed, then they will go take a look. But acutely, a lot of people don't take a look. Dr. Velchek still goes take a look. This kid that we had, the twin, wasn't acute. It was a chronic thing then. We couldn't feed the baby. Wasn't passing any stool. There's still persistent thrombocytopenia, so that's why he took a look. But when the acute phase and the kid's abdomen gets discolored, most they just put a drain in. They won't go in. Most common is the located in terminal ileum and the proximal colon, right? It's the vascular supply, you can see, right? Again, no one knows what the cause is. It could be hypoxia, ischemia, then reperfusion, infection, umbilical cat. We don't really see that because our incidence was very low. I can't say umbilical catheterization is a big problem here. Hypertension, right? Again, polycythemia, maternal cocaine. We've had it in the past. There is a change in the vascular constriction. My mom does the cocaine because it can affect the vessels in the baby and the placenta. All right, and again, there's multifactorial, like they said, right? Questionable feeds, right? Again, a lot of centers, like I told you before when we talk about growth, there was a big push in neonatology about they call it the Z value, about babies coming AGA and leaving SGA. So the big push to feed these babies, right? And everybody that comes to me with these high calorie formulas, increased protein, all this and like that, I always ask them one question, the formula companies. I said, so what is the incidence of NEC? Oh, we haven't seen an increase in incidence. But what I say is, I wanted to know what their incidence was, these places that were studying this, okay? So if they're accepting a high incidence already, then you're telling me to do what they do, you know what I mean? So that's why I tend to not go ahead and jump into things right away and start new formulas or fortifiers, because of that. All right. Again, immaturity, you saw all the different factors. I told you that. Again, talk about that. Let's go. Multifactorial, told you. We had some, we call it pseudo, right? And we had some viral illnesses that we get, and you get almost looks like pneumatosis, dilated bowel, bloody stools, but the kid clinically doesn't look sick, all right? Very active. They have some viral infections in the unit over the couple of years. And I told you the age, right? Less than 30 weeks, 20, age of diagnosis 20 weeks out, right? Full term, remember that. Downstairs, he's distended, irritable, bowel tense. It's not out of the ordinary. Can it be NEC? GI signs, right? Abdominal distension, right? Blood in the stool, right? Absent bowel sounds. You get blood through the pulmonary tube. Again, decreased stooling, right? Why are we worried about residuals when the nurse checks? Discoloration, visible loops on these little ones. You can actually see the loops, dilated loops, when you look at them, when you go around looking at them. Okay, and we could start rounds in a nursery, bed 1, and walk around to bed 2. About time we get to bed, walk out the door and past bed 1, you can see this. That's how quick I've seen it happen. And you can see the discoloration. You see the visible loops, right? So, a lot of units put these babies on feeding pumps. Why? Because it's staffing, right? You put them on a feeding pump, you feed them over a half an hour or a little longer, and you walk away, the nurse. Over here, we feed them through gravity. The nurse will sit there with the tube and let the tube rise and watch the food go in. And she could tell, if the kids are regurgitating, they'll let us know that the baby's not tolerating the feeds. They complain about it because they'd rather put it on a tube and not be bothered. But I don't know why the incidence is low in the unit, so I didn't change it. They tell me that I don't value their opinion, but I just told you I'm valuing your opinion, right? As time goes along, they have a lot of experience, and they can tell you that the baby's not feeding well, and they just say, don't push the baby. You understand? It's a lot visual, but to try to have people buy into it sometimes, right? Again, temperature stability, meaning they get hypothermic all of a sudden. So A's and B's. You got a growing preemie, and all of a sudden you're starting to have an apnea and bradycardia. First thing on your list is watch out. Yes, necrotizing colitis or starting, right? Of course, metabolic acidosis is an ominous sign. This, we already missed the boat. Erythema of the abdominal wall. Okay. Ileus, bowel wall thickening, right? Distended, we call them sentinel loops. So literally, when we used to have the old films, now you got to pull up all the films next to each other. But if you pull up the old films, you can literally put them over each other, and that same loop is there. It's a sentinel loop. It has not moved, right? Pneumatosis, intestinalis, intramural gas, right? This is, again, you cannot see it on these screens over here, right? Because the resolution is not good. But if you go to radiology, they have a better resolution with the screens, right? You can see. That's why one patient there, that's why they gave me an older model. The resolution is still not the greatest, but they gave me one of the radiology screens there, the better resolution. Because when we went downstairs to look at the kid, there was a paravenous portal gas, right? We didn't see it upstairs, okay? Neutropenia, thrombocytopenia, they go into DIC, right? So they call the Bell's classification in terms of, so this is a modified. Stage 1, you suspect some clinical findings. X-ray, normal or mild ileus bowel. The problem with that is, right, so, you know, when neonatology, you tend to err on the side of caution, back off, but also you have to feed. So you don't back off for every time you think it's NEC, you're going to back off for a whole week. Some units are like that. Some neonatologists are like that. Especially when you're rotating in and out and you don't see the kids all the time. Very difficult to make a decision like that, you know. So you tend to, the incidence of NPO goes up in the unit. So stage 2, definitely see more obvious clinical findings, right? X-ray, you can see pneumatosis. Stage 3, advanced NEC, severe clinical findings. Pneumatosis, that's not ascites, perforation. I mean, this is what I was talking about here. This is just approximately 30% of the patients with radiographic evidence of pneumatosis test have mild disease and require a period of bowel rest, but not surgical. So that's the whole thing. The medical treatment, bowel rest, right? You want to back off on the feeds. At this point, we want to perfuse the gut, so we increase the fluid. You can put them up to 200 cc's per kg. Sometimes, if you really think it's NEC, right, I'll put the fluid up. Mm-hmm. So, in other words, on a preemie, you're going to forego the respiratory system, right? And you're going to go ahead and try to perfuse the baby, all right? Mm-hmm. Make sure that the gut is being perfused. Eventually, and then another 30% will succumb to disease, rapid deterioration and death, which is not pretty to see. All right. So this is just, you know, the whole, again, cascade. And again, these markers, you know, people talked about it, my God, we've been talking about for years. People do the markers. I mean, it's not really available, but they would help in terms of doing some of these markers quickly and seeing what's going on, so you know that there's some sort of injury. Again, you know, multifactorial, right? What's causing it? You know, is it ischemia? Is it feeding problems? Is it the formula itself? Is it breastfeeding? Is decreased? I mean, for years we still had a low incidence of necrotizing enterocolitis here. We weren't pushing the breast milk, or the breastfeeding was low in the unit. Again, this is not evidence-based in terms of, but we use a criteria of going up no more than 20 mLs per kg per day on these babies. Still use it. Everybody still pretty much uses it, even though everybody says it's not evidence-based. Some people that, if you talk to the GI guys, they come and do nutritional rounds in the units at big places, or feed this, feed that. If you follow them, you're going to have more NEC. They only look at one part. So you take everybody's consults with a grain of salt. Caution it if acute illness or perinatal asphyxia, of course. That's why we omit some of these kids that we had a bag, low APGAR, any APGAR less than 6, they bring upstairs automatically. Well, I'll tell you to do a gas downstairs in newborn nursery. If the baby was acidotic, don't bring the baby up. Now, why the baby's acidotic? He's showing you that he had a fluid shift, right? So if he has a diarrheal reflex, right, and he had acidosis at birth, he diverted blood away from his GI tract. Mm-hmm. So when you go to feed them, there could be an area of ischemia. So when you feed an ischemic gut, what happens? That part that is ischemic, the peristalsis still needs to occur to digest, right? So the muscles are moving, right? The more the muscles move, the more energy required, but it's ischemic. The blood can't get there, then you're going to pop, perforate, all right? So that's why when the kid's acidotic, we don't feed them right away. We wait till they have bowel sounds, bowel movement. All right.
Mhm.
And you see here the pneumatosis, extensive. Huh?
Mhm.
Paucity of air, you don't see much air. So the problem is that you may not see free air. There may be already perforation here. Why? Because the air never went to the where that area of perforation was, because there's ileus. So the air's not going to move. Right? He doesn't have an. He has. I don't see. No, there's no NG tube in this kid. Again, like I said, decompress. I told you on the floor. You had that kid on the floor, right?
Mhm.
That came up from the ER.
Mhm.
The minute you put the Repulgo tube in, the Repulgo tube is a double barrel tube, right? One
Mhm.
port is open to air, one port suctions.
Mhm.
As you suck, the air is drawn in from the outside, so the tube hopefully doesn't adhere to the stomach line. When you put those in, and the nurse puts it into all continuous suction, you should see a change in your bowel pattern, right? You should see decrease. So a kid who vomits with a Repulgo tube, the tube is obstructed because it's supposed to suction everything out of the stomach. Should be nothing to vomit. If the air is not by the next X-ray, you should do when the kid's that's distended on the floor. You don't need a CAT scan. They should have did a CAT X-ray in the ER,
Mhm.
X-ray on the floor, and see the bowel pattern. You want to see the kid decompress. So putting Repulgo tube is you decompress from above, right? And then of course your finger you decompress from below. All right. You don't give cathartics from above when you got that much dilation. You do either cathartics from below or you decompress manually from below and see if you get anything out. And you use the suction to decompress the loops. If you don't decompress, either there's an ileus or there's a closed fixed loop obstruction, right? You're in trouble, right? Acidosis is a good marker. If the kid's getting acidotic, you're in trouble, right? That means something's dying, all right? So again, uh, broad spectrum antibiotics, frequent X-rays we do next door, okay? Right. So what?
Do we get antibiotics in necrotitis NAC or not?
Yeah, you give antibiotics because we don't know what etiology. So you see ileus, right?
Yeah.
It could be mechanical, could not be anything related to infectious. But like I told you, once you damage the mucosa, that the GI flora can go across and go into the bloodstream. So that's why you give antibiotics, right? So you don't know if the infection came first or afterwards.
Yeah, that's why I was like, this was
When you
my
start
question.
antibiotics, you're foolish not to start antibiotics. You're asking for trouble.
Okay.
Okay, because sepsis in the newborn. That's why, this bullshit with the sepsis code. When I walked into this institution, Dr. Harron would yell at us in the NICU if we didn't get the antibiotics in within a half an hour. So he was doing sepsis codes from whenever I was a resident here since 91. He was doing sepsis codes. It took for somebody to die in New York in a hospital in the ER, everybody go, oh, we need to do a sepsis code. And Dr. Lemma did the thing, but I was laughing when she was doing the protocol. I said, come on, you know what Dr. Harron taught us. We used to friggin' do, get yelled at. All right? And every case in the ER, when we used to discuss it, you guys, right? We had a kid die of E. coli years ago that came from the ER and they transferred to the NICU, right? There was a delay in the ER pushing antibiotics. So you don't want to delay. Why? Because you're going to live with the rest of your life saying, oh, I had started the antibiotics. They do not. So if you do everything the right way, you're still going to may lose them. But if you do something wrong, you're going to be regretted for the rest of your life. All right? Okay? There was a pediatrician, she's practicing Dr. Dayuda that works in Dr. Lemmer's office. There was the graduation party. So she was the second year on with the night attending there, right? Kid came in, GBS, got the antibiotics right away. Within an hour, starts bleeding, boom, 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 DIC, and dies, right? Within 2 hours. That's how quick. All right? But antibiotics were pushed, okay? You never want to delay. You never know what. All right. Same thing with meningitis. If you miss it in the office, start getting to go. The kid's gonna die in you. All right. Even if you treat him, hopefully you can prevent the sequela. The kid's gonna be sick. So that's what the sepsis code is about. But this is what we practiced in the unit forever, and we haven't changed. Get the antibiotics, push the antibiotics. All right. So this is you see is dilated loops, right? Now, what these kids is they remember they're prone that's laying there. We do an X-ray. You look, the liver is an area you can use to distinguish air, free air. But usually the air will sit right here. Okay? So when you look at these little ones, you look for the perforation right here. And then the perforation will extend. All right? Okay? Why I know that? Because I missed one. Then I walked in behind the time Dr. Harron and Dr. Lance again was standing there in the lunchroom in the NICU looking at X-ray, and I had come in and I walked in and said perforated. And they looked at me. I said, look, and the air was right here. Okay, and sure enough, when we put the cubitus, we put the left side down, right side up. The air went above the liver, and you can see it. Use area the liver as a contrast medium, right? Okay, you can see there's a dye they put in. Again, depending on the surgeon, right now they're just putting drains in and waiting it out if the kid's real sick. You can see here, right? So left lateral of the cube, you use the liver. That kid, that's that same kid, right? So they did upper GI on the kid, or barium or whatever, because he had dilated loops. It's not the greatest thing to do if you take an NEC, but you can see he's perforated, right? You see the air? Right. And then you documented it by turning the baby over. Here's the liver, and there's the free air. Okay? Air rising, right? Okay. So, again, like I told you, mortality rate over the years, especially when it's full-blown, not much you can do. Sepsis, DIC, shock. The problem, the outcomes, because you're a prolonged TPN afterwards, you get cholestatic liver disease, right? Again, the longer you keep the essential line in, you get infections after that. So this all adds up to the morbidities in the NICU. Malabsorption depends on how much ballast you took off. Short gut syndrome, right? Even if those kids that recover by themselves that have a Bell stage 2, right? Maybe ischemic area with the pneumatosis that recovers, they may recover and form a stricture, right? If they have little peritonitis, there may be adhesions and you get an obstruction that way, okay? GI dysfunction, 10% of the survivors. Major growth delay, 30 to 50%. These kids always end up leaving the unit, SGA. Major neurological development, of course, because they're sick, all right? So you got to ventilate them more. They have more apnea. They have more, desaturations. They get more lung disease. You're pumping them full of fluid, causing chronic lung disease. So that all adds up and increases the morbidities in the NICU, and the outcomes change. Okay, so when do you expect meconium, right? By 24 to 48 hours of life, 99% are healthy to pass meconium. Preterm infants up to 9 days. We promote it right away with these little ones. We give them a glycerin suppository. Why? To get the stool, get things moving. We don't wait and sit. All right. By 24 hours, term newborns have air all the way down to the rectum. That can be visualized by KUB. By 12 hours, 99% have infants that pass urine. Normally, the urine output is anywhere from a half cc to 1 ml kg per hour. All right. So, immune thrombocytopenia, autoimmune disorder, etiology unknown, neonatal effects. Maternal IgG antibodies may cross to the fetus, leads to fetal thrombocytopenia. This may occur even if the pregnant woman had a splenectomy, because the maternal antibodies are still present. So the history is important when you go downstairs and your mom had ITP, you get a history, right? You have to do that. So if they know the history of the baby's platelet counts less than 50 down, then they may suggest to a C-section, right? All right. So just in terms of what can affect the kids, this could be most of the time with the myasthenia gravis, right? Limited fetal effects, but some kids can be born with arthrogryposis, right? Fixed joints are fixed. Polyhydramnios because they don't suck, right? Affects about 10%, 10 to 20% of neonates will develop transient myasthenia. We usually do the tensilon test. Give them tensilon, and see how they respond. If they're toned, they were hypotonic and stuff like that. Done it a couple of times with Dr. I haven't done it in years. But I don't know if with Dr. DeCarlo to tell you about it. All respond to anticholinergics, right? Excellent recovery. 90% of affected infants recover within 2 months of age. So the maternal antibodies are going to stand around for 2 months, right? So these kids could be hypertonic, right? Okay, so they may give you a whole history of boards about this, and then give you a baby comes out, hypertonic. What is it, right? Or what would you use? Tensilon, right? Hypothyroidism, right, occurs in approximately 0.2% of the pregnancies, and it results in a significant increase in prevalence of both low birth weight, delivery, and the trend toward an increase in neonatal mortality. Most common cause of thyroid toxicosis, 55%, Graves' disease, okay. So how do they manage mom? They give PTU, right? The courses, but slower than methylmenazole. Propranolol is associated with IUGR, impaired response of the fetus to anoxic stress, and postnatal bradycardia and hypoglycemia. So when a baby's on propranolol, a mom's on propranolol, you gotta look for the side effects of the baby, right? And of course, iodide fetuses may develop goiter, can be obstructed. Approximately 1% of infants born to mothers with somebody have themselves thyroid toxicosis. So, I saw it in fellowship. We had a set of twins. Mom was on medication, and the minute the medication wore off, the baby came, or both of them became tachycardic, right? And so we had to start them on propranolol, both of the kids, newborns, until the maternal effect wore off the babies, right? Hypothyroidism causes mother chronic thyroiditis, previous treatment for Graves' disease, okay? So usually well tolerated by the infant. So it's just a matter of just getting the history and why mom was hypothyroid, right? Because then you look at any effects of the baby, make sure you get the thyroid profile on the baby earlier. Because of mother's severe hypothyroid disease, ovulation, of course, fetal loss prolongation of gestation. No method to present to diagnose hypothyroid in utero, baby, right? The big thing with the SLE, with the mother who has a SLE, they'll give you a history mom has done, is a congenital heart block. That's the question on the boards, right? Mm-hmm. That's the biggest thing. Anti-Ro, anti-La, right? Remember heart block, that's going to be the question. So they'll give you a whole history. Mom born premature, baby, mom was IVF, history of lupus, blah, blah, blah. And then the babies, and they may show EKG. And you remember.
So each mom with SLA we do an EKG in the baby?
You should do EKG, yeah. So when I've talked about, you can see the growth, right? The mean weight, right? So you can see as you get more multiples, right, the weight will fall off earlier on, okay? So with twins, you can see here, they don't start falling off until around 30 weeks, right? right? With triplets, you see they're falling off around, the weight starts falling off around 28 weeks. Okay? This you don't have to need to. So, um, so this one here is what you worry about, right? The monozygotic, right? Diana. Um, so the typical questions is the twins, right? And the risk for so when the baby comes out anemic, they'll they're looking for the answer of the twin transfusion. There's a connection, vascular connection. So there's the donor and the recipient, right?
Mhm.
So the donor is going to be usually SGA like that other one over there that just came, right? The recipient is going to be polycythemic, right?
Yeah, hyperviscosity.
And maybe LGA,
Mhm.
right? And they die because of the polycythemia, right? Find out. The other one may die because of severe anemia, but that's you may lose both of them, all right? We talked about that. Okay. Birth trauma. Okay, so risk factors: first baby, right? Prematurity, cephalopelvic disproportionate, abnormal presentation, prolonged labor, instrumentation, oligohydramnios, right? Macrosomial distortion. Right? So you have the layers, right? So the caput is between the skin and scaleo the epidurosis, right? So you have caput. Cephalohematoma, you see, here's the periosteum, right? It doesn't cross the, right? And the subgaleal, you see it's a huge space, okay? Okay, subgaleal space. So you take a tremendous amount of blood. So if you have a rip in that area, these kids become hemodynamics unstable and can die from that. All right, so you got to recognize it. Their head swells up, and usually the swelling goes behind the ear, right? It goes down and over the ear, behind the ear. You'll see the swelling. It can take a massive amount of blood, right? So these kids they'll become hemodynamically unstable. You're going to have to transfuse them, right? Why did they leave? They're on the floor? For what? You have two patients. I don't understand, but yeah, I could have 20-something patients in, he's here. Come on, I don't understand why somebody, it's supposed to be protected time.
Mhm.
It should be protected time. I mean, come on. I can understand if you were busy. Trauma, common types, caput secundum, right? Vaguely demarcated area of edema above the periosteum, extends across the midline of the skull, across the suture lines. Often ecchymosis over the skin resolves within several days, right?
The one that we had on Wednesday does look like a cephalon.
Who?
The second twin B.
No, well, that's the instrumentation, but it was anterior over here. It's gone already.
Is one.
Yeah, because that area is not that type of thing. I was worried about the eye. I got to take a look at it. The eye. Cephalohematoma, supraperiosteal collection of blood, sharply demarcated, limited by periosteal attachments, does not cross the suture line. All right. So sharp periosteal limited in the bone, absence of overlying discoloration, lateral initially appearance of a swelling. So this lasts for 6 weeks. And what happens with this is that there's blood, right? So the blood gets calcified. Look at that. There's somebody
No,
else.
it's not us.
Somebody
No, it's
doesn't
Yeah,
carry
Zoom.
with that. So with this, that's why you should pick it up in newborn nursery. If you don't pick it up in newborn nursery and the baby comes into the ER, it starts to heal like a depressed skull fracture. The cephalema, true cephalhematoma. So that means it gets calcified, and then you feel like a little depression. So you could falsely accuse the mother of child abuse and stuff like that. So you have to make sure you guys don't miss it in newborn. Document it so that the baby goes somewhere that they have a documentation will drive the parents crazy. continue associated with complex anemia, of course. Hyperbilirubinemia, skull fracture. It could be on the intracranial hemorrhages, right? Which is significant. Like I said, like I told you before, I wanted to do a birth trauma scale downstairs years ago, and get like a scoring system downstairs, and then if they meet the criteria, go ahead and do the CT scan. Let's see if you see any intracranial bleeding. With severe trauma, there molding, suffering hematoma, the baby's irritable, things like that, and see if there's a correlation. But if you did a CAT scan on a lot of these babies, you'll see some small blood in the subarachnoid space. They're irritable. All right. So, like I said to you, present at birth or normal vaginal delivery appears within a few days after birth, or normal at forceps delivery. Again, with the sutures, this is well defined. The hot edge is across the suture line. Soft pits on pressure, soft elastic, but does not pit on pressure. Skin ecchymotic, no skin change. Size largest at birth, gradually subsides, becomes larger as the blood is going in, right? No underlying skull bone fracture with caput. You may have a skull fracture depending on what they use to deliver, right? Again, both of them, you don't aspirate, no treatment, both of them. Clavicula is the most common fracture during labor and delivery, associated with shoulder dystocia or breach, the green strip type fracture, present deformity and dislocation over the site, decreased movement of the arm passive movement of the arm, elicits pain, tenderness, crepitus with palpitation, absent moral reflex. Treatment, direct, total, depending. Every year they change. Mobilized or mobilized, but it's hard to immobilize a baby unless they're really having issues with pain. And it heals pretty rapidly. You can see 7 to 10 days you start getting a count, right? Brachial palsy, paralysis involving muscle of the upper extremity, following trauma to the spinal cord, C5 to T1, right? So herbs you get from anywhere C5 to C6. Position of the arm is abducted and internally rotated. Extension at the elbow, pronation of the forearm, and flexion of the wrist. So just remember, waiter's tip, right? So as the waiter walks away, he puts out his arm behind you, and okay. Absent moral grasp reflex, intact, some sensory deficit. May have respiratory distress secondary to accompanied ipsilateral phrenic nerves. So you can see seesawing of the diaphragm and the lung, chest wall, right? Klumpke, rare lower paralysis secondary to C8 to T1 injury, paralyzed hand, absent grasp reflex, dependent edema of the hand, forearm, sensory impairment on the side of the forearm. May be accompanied by Horner's syndrome, right? Cervical spinatic nerve injury with meiosis, right? On the ipsilateral side. Entire arm, complete, motionless, flaccid hangs. All reflexes are absent, sensory deficits. Sent to the shoulder. So that's a lawsuit, right? Treatment, aim to prevention of contractions, partial immobilization. So anything else, when you first have acute injury, you want to not stress the nerve, let the inflammation subside. So 1 to 2 weeks, you don't do much, just positioning, followed by then they do rehab, right? Lower arm paralysis carries poor prognosis, core deformities may develop. Upper arm paralysis will recover in 3 to 6 months. So that's a long 3 to 6 months. Entire arm paralysis may not recover, some function eventually. Facial nerve palsy, we don't see much, but You can see one thing is we don't hardly do any forceps, if anything. We don't do. So follows compression of the nerve secondary to forceps, prolonged pressure. Peripheral paralysis flaccid may involve the entire side of the face, eyes. Affected side may be persistently open, mouth drawn to the normal side during crying, right? Asymmetrical cry. Treatment, no specific treatment. Protection of the cornea, complete peripheral, complete peripheral paralysis. Most resolve within 7 days. Differentiated from Mobius syndrome, agenesis of the facial nerve, nucleus, and resulting bilateral and mobile expression of the face. Right? Subcutaneous fat necrosis, right? So anything that you put pressure on these kids, they get subcutaneous necrosis from inside to out, right? So with large infants at birth trauma, we had one kid that years ago that Dr. Mukherjee was shoulder surgery got trapped. He put his hand in behind the kid's butt and pulled the kid out. But then again, I did put a line in the baby that went down to the foot. Chances are that the line clotted off the vessel and caused necrosis. You don't know whether or not the trauma, but that kid ended up getting a fat necrosis inside out. That means that the whole gluteal area became necrotic. Right? May result from diminished uterine circulation and mechanical pressure during labor and delivery. Right? Eventually necrosis may calcify it, but most resolve spontaneously. Anemia, hemorrhagic, fetal maternal transfusion detectable in 50% in pregnancies. Anemia in only 1%. Diagnosed by Claire Becky, right? Maternal blood greater than 1%, fetal blood equals 50 mLs of fetal blood. So that's how they determine the percentage. That's how they determine how many vials or Rogram they got to give mom, right? By the KB. So test done with maternal blood detects fetal cells. Blood is treated with citric acid phosphate buffer, right? At this pH, the adult hemoglobin is soluble and dissolves out. Fetal remains precipitate and is stained with on the slide, right? And it appears and the mother's blood appears as ghost cells. The baby stains red. So percentage of fetal hemoglobin, fetal cells, and time, number of maternal cells times 100, right? Then it goes at 1% hemoglobin, approximately 50 mLs of blood. Vials of Rogram equals mLs of fetal blood, all right? You can get, of course, false positives at any time. Increased maternal hemoglobin. If mom has tau, false positive. False negative results, blood group incompatibilities. So what does that mean? So if the baby is, that's why you gotta do it right away. If the baby's anemic, you gotta do the right away. Because if there's an ABO compatibility, mom is gonna chew up the baby's blood right away, so you won't see any fetal cells. So the test will be falsely negative, right? This is protective in RH disease, right? ABO incompatibility protects in RH disease. App test. App test is done on the fetal sample size, right? Blood aspirate, detect maternal blood. Treatment, blood with stomach acid. Remember, stomach acid, they're going to use base. So you use sodium hydroxide. Fetal hemoglobin is resistant, again, to acid and alcohol, right? So unlike adult, right? So on the slide, fetal hemoglobin is pink, adult is yellow, brown. So if there's yellow, it turns yellow brown, that's maternal blood. If it's pink, it's baby's blood. We don't do
This is BK. Apt?
Apt
Okay, no,
test.
you can go.
The KB test, you use what? Acid.
Yeah.
Okay?
It's apt test.
So, again, twin to twin, average coronal pregnancy have 50% incidence in both anemia. I talked about this central birth, internal hemorrhage. So, I told you this the other day, right? It takes about 6 to 12 hours to for the hemodilution, right? So it's the equivalent rate, right? So if the baby comes out, loses whole blood, then the intravascular volume has to increase. So interstitial fluid goes into the vascular space, and then you may not see anemia initially, but later, if you repeat it 6 to 12 hours, you see the anemia. Just a terminal, we haven't had one in a long time, but who knows if we missed it. That's rare. We had one in the past. Autosomal dominant recessive. Again, anemia unexplained. You have to look for a reason. And that's when you say the smear for the hematologist, right? Macrocytic anemia in the first year of life associated with other anomalies, short stature, musculoskeletal of the heart, absent erythroid precursors in the bone marrow for diagnosis. So they would need chronic transfusion, steroid, and bone marrow transplant. So these are underproduction, Fanconi's, autosomal recessive. You have musculoskeletal abnormalities.
Can you pick up for Dr. Visconti, please?
Chromosomal instability, right? Progressive pancytopenia, supposed to leukemia, lymphoma, bone marrow transplant also. Acquired erythroid aplasia, aplastic crisis, or hemolytic disease. You can get with if mom is excuse me, when the kids are in school in the season, fifth disease, right? That's why the teachers always worry about being pregnant during the school year because of the fifth disease. They get parvovirus and get it's the cause of high drops, right?
Yeah.
It's even maternal drug use. We don't always see that anymore. And infectious hepatitis. Folic acid and B12 deficiencies, macrocytosis, with or without anemia, hypothyroidism, trisomy 21, spleen, of course, some heart diseases, because in a heart disease they may not be asplenia. Again, this is more for the exam purposes. There's a big differential, all right? Boring stuff, but you got to remember it. Hemolytic ABO incompatibility may occur in the first pregnancies without progression in subsequent pregnancies, or they may progress. Mild hemolysis, direct Coombs may be positive. Sites on the smear, late anemia after first month. So mom's antibodies is gonna be in the baby, right? Usually anemia is persistent. So that's why you have to follow these kids as a pediatrician, right? Because the physiological nadir is in 2 months of life. So the baby's already hemolyzing. So it's going to have double issues, right? So severe ABO incompatibility, they may end up getting transfused later on, right? RH incompatibility, 3 linked genes, allele expressions, right? ABO incompatibility may be protected, like I told you, because before the mom can get exposed to the RH factor, the baby mom already reacts to the blood incompatibility and destroys the cell, right? Clinical severity increases with each pregnancy, so this one will increase. So the first you may not see much, second you see worse as it goes along, right? Again, that's why they give the raw gamma. That's why you have to determine the KB. What's happening here?
Probably hold on.
Who? Me?
Yeah.
I didn't write it. alpha tau, alpha tau, right? Severe based upon the number of gene expression. Alpha globin change predominant. See, something's good. It's getting fancy. Form. I must have hit something. Mid gestation. Therefore, defects may detected at birth. All right. They usually not usually diagnosed.
Maybe
Oh, see,
someone is right.
no, it's me. I don't know. Somebody's right. Usually diagnosed before 6 months.
I think there's in Zoom you can like go right with the arrows also.
Okay.
That's fine.
Before 6 months of life, unless the blood loss or red cell destruction creates a unusual high demand for replacement of red cells. So not usually diagnosed before it's beta tau, right? Hereditary, again, this is the cause of jaundice that once we don't know, the baby comes in and there's no ABO incompatibility, it's jaundice, then you have to start looking. That's why we say you always save the smear, right? Tell you save the smear downstairs, so the hematologist can look. Don't assume that it's always ABO. Make sure that you're not missing something. So autosomal dominant neonatal jaundice with splenomegaly. That's why examine, look for the spleen. Spherocytes always present. Again, these are all membrane disorders, right? That you're going to pick up on a smear. Vitamin E deficiency, right? We always gave vitamin E in the unit in ICU. Now we give it with the polyrysol. Nobody knows what exactly how much, but I know in the past that the ones that we didn't start anything on, we would get this anemia. They get a little edematous, these kids, all right? Peripheral edema, you know, these the preterms growing. So you got to be careful of vitamin E deficiency. So we always used to give, here, in fellowship, we gave it right at birth. We started for 7 days, I think. Here we started it on when they started feeding full feeds. Hemorrhagic disease of newborn, vitamin K deficiency we talked about, right? Yeah, breastfeeding, talking about that. Hemophilia A and B. Oh, this is the one downstairs. So, we had a baby last night, mom, right? Was born. Don't ask me. It ticks me off that this mother giving birth and nobody knows her diagnosis. But you can't diagnose it during pregnancy because the factor VIII may increase, so her levels may be normal, but yet she'll have the disease. So they gave the mother DDAVP. So they're gonna. They told them to talk to Dr. Peshoff. They told you,
We
right?
talked already, and he ordered the PTT and the Cupertinos also, and I draw the blood.
Level 2
I think it
adult
was
trauma
Venus
in the
or
emergency
Venus.
room. Level 2
Yeah,
adult
no, I
trauma in the
asked,
emergency
and
room.
and he was clotting.
It would have been good if we had done through the cord, but unfortunately they didn't have the thickened tube, the sterile tube. We didn't have the sterile blue tube, so they only had the lavender. But then I realized the lavender was not good, so I couldn't do it. But they say you can do it through the cord blood. So excellence disorder incidence is 1 in 10,000 males. Hemophilia A, factor VIII deficient 70.
Mom has 8.
7, they said extra 7 factor 8.
It
Who don't know?
makes
Who don't
no
know?
freaking sense.
Yes. I thought it was bone very bad.
I mean, I don't know. It got me so.
But she didn't get any blood transfusion, right?
I don't know what happened afterwards. She was she
She
clotted at birth,
Okay.
and we walked out. So bleeding from vena puncture sites, umbilical stump, circumcision. That's usually how we tell. The baby male gets a circumcised, starts bleeding. So then you do your PTT downstairs.
We had one.
Right.
We have one that actually.
So neonatal immune thrombocytopenia purpura, prevalence 1 in 2,000. Mother normal platelet count. If mother's PLG antigen is so this is isoimmune, right? So a negative. This is like RH. Mom is negative, baby's positive. This can happen early on. Can happen during the first pregnancy. Accounts for some losses that the obstetrician didn't even know about. Infant possesses a platelet antigen. It is in the placenta. He said transplacental passage IgG. sensitize the fetal platelets, the antenatal intracranial hemorrhage is possible, right? So this is not, with ITP, baby's less likely to bleed, even though platelet count is low. But with this, with the isoimmune, the baby can have an intracranial hemorrhage. So if you misdiagnose it and you don't pick it up, right, and baby's delivered through a traumatic vaginal delivery, they can bleed. So autoimmune, right, is passive acquired maternal antibodies, right? Okay, I have normal platelet count, right? But I told you that before. So autoimmune is the ITP, right? Isoimmune is the PLA. Then you can have platelet disorders, production disorders, thrombocytopenia, have not seen one in a long time, but at least a couple, right? Was called Aldrich, right? X-linked immune deficiency with eczema. Obviously eczema. But this one is impressive. You'll see absent radius. So they'll show you X-ray on the boards, or they'll talk about baby that has thrombocytopenia, right? What would you do? Acquired isoimmune maternal hypertension. Okay. So these mothers that neutropenia, mothers who are severely preeclamptic, these babies sometimes will come out neutropenic. Of course, it's something that we worry about that is infection, but sometimes just the preeclampsia itself, these babies will come out neutropenic. Again, rare disorder, rare autosomal recessive, okay, albinism, Cosmic, you get neutropenia, autosomal recessive, orpholitis, right? Almond diamond, autosomal recessive again. So I think the list is even more. And these are the more common ones. Again, depending on the temperament of the boards. When you see this in a matching column, you say somebody, the cursing underneath your lips, and I can't believe they're asking these questions because it's like Trivial Pursuit. I mean, when they start going this depth, but sometimes it varies on what they decide what they're going to focus on. So those are the things that you just go over, hopefully you remember. Because they're not that frequent, you don't see that much, but you know that they're out there. Again, essential criteria must meet all four. Defines acute intrapartum hypoxia. You gotta be careful when you write asphyxia in your notes, all right? Especially for the obstetrician, it's not good that you write asphyxia. Metabolic, I said before, base head set for above 12, base left step. Early onset severe moderate neonatal encephalopathy. Infants usually greater than 34 weeks. Again, can have spastic quadriplegic, right? It could be, again, there's other things that can occur. What's that?
Yeah, umbilical cyst.
Yeah,
or one vaginal cyst. Yeah.
4 cysts of cord. 1 gel is the area of the liquefaction of jelly. Occurs up to 20% of infants. This condition has no association with anomalies.
Yeah, ductal stenosis or cyst. Cyst. No.
Yeah, but what is it called? The right.
Yeah.
Mucocele. Disorder of nasolacrimal drainage system with excessive watery eyes, atresia of lacrimal duct, congenital mucocele lacrimal sac, right? Congenital obstruction, right? So what you have to worry about is that it can get infected, so you see here, so most of them are in the birth, right, onset, right, neonatal period. Dactyl seal, you see is blue-gray. This is when you start getting infected. erythema, right? You can see blue or gray, and this one is encephalocele. Any midline lesion, you have to worry about encephalocele, right? Midline, right? You can see an encephalocele, right? That means extension into the brain, right? We had one in the posterior pharynx, right? So every time the baby cried, they would increase the size and cause an upper respiratory tract obstruction, right? Till it burst, and you leak CSF, right? You could transilluminate these two, right? X-ray changes rare, no, yes, and this one is suffer. You could see. You do a CT scan extension into the brain. If you aspirate, CSF is going to be on the encephalocele. You don't really want to aspirate. Hemangiomas, you don't want to aspirate, right? So you usually don't aspirate. I'm just telling you, people who've done it, and this is what they got. And this is what they were talking about, the canthal tendon, right? The lacrimal sac, right? And this could be just an obstruction. What's that?
Suppose
Could be, or
could be.
what? It's just required. This condition is defined for facial nerve palsy.
Yeah.
And that is that the eye and the forehead muscles are unaffected. The etiology is congenital deficiency or absence of the pressor angularis, right? Oris muscle, which controls the downward motion of the lip. This is a patient has left side is affected. The left side, right? So you can see the eyes are closed, right? So that's not facial, right? Pause. You differentiate. Absent, relax that the pressor. So it doesn't depress when he's crying. Okay.
Yeah, one.
Yeah. Just know that's there. Webbed penis is another congenital. You know who was our expert? You don't know Robin. Robin was our PA. I don't know why, but she was. So I used to call her the expert in hypospadias and many fetus abnormalities. We call her. So, to ask Mary, who was the expert when you go into units? Mary, who was the expert in diagnosing hypospadias? PA, which one? So start laughing. We should make fun of Robin. She used to, but she was good at it. She'd pick up things right away. You know, abnormalities all the time. So anytime I said to Sir Claire, ask Robin. Pearls. See the pearls?
Yeah.
White bumps present in the upper gum and infants of Momus nodules. Exactly known, but they are thought to arise from amendments of dental lamina or from hypertrophic salivary glands, present either lateral gum. Findings will disappear in time. Right? So this reassurance. Tongue-tied, everybody's tongue-tied. Yeah. Big, how would you say, business. People cut the tongue tie. Yes.
Yeah, basically. This from the electrode sometimes.
Well, you can get midline lesions, but you have to start taking and looking at the baby once you see this. Aplasia cutis congenita over the posterior occiput, right? And then this is cleft lip, 67%. So what's going to be the diagnosis? Cleft lip, 60 to 80% cleft. Palatal bone, right? Polypolencephaly. Trisomy 13. So any midline lesions, you start looking. The scalp lesions, right? Associated with trisomy 13, right? Because then you start looking at the rest of the baby and see if there's anything. right? Clenched hand, fist, overriding, right? Fingers, hyperplasia, right? Ulnar radial deviation, hypoplastic thumbs. What is it? What? Wakabata feet, right? So trisomy 18. Okay. Wide a gap between the first and second toe. Good. Fundactia, right? Single flexion crease, short, broad, and right? Permanent flexion, right? So the trisomy 21, hypotonia, moral, hypomorphexia of the joints, excessive skin or back of the neck. That's when you see in utero, right? Flat facial profile, slanted fissures, anomalous, all right? Dysplasia of the pelvis. So a lot of these things have to do with what you do later on in life in terms of. Hello? Hello? Yeah, right. I hate, you don't know which is real or which is not. It's dysplasia, okay. What's is this?
Needle is really when it's on the man. No? I don't know what's the first one.
Prader-Willi, right? So Prader-Willi. So you can miss this, but the secretions, one thing is that the secretions are very thick, mostly, right? But 70% are due to deletion of 15 to 25% are so 25%. So we 5% of maternal. Forget about that. Just remember it's 15Q if they ask you. The rest of the stuff they're not going to ask. But just small hands, feet, undescended testing, hypotonic obesity later on, right? So the kids are hypotonic and they may not be large inside the NICU. They may have feeding problems we had before. Secretions are thick, all right? You can miss the diagnosis in the NICU. So, yeah.
Why do they start off hypotonic and then become obese? What's like the reason?
They have laxity of ligaments. Also.
But the hypotonia, like I said, what do you mean obese? The obesity has to do with that.
For Prader-Willi?
Yeah.
Prader-Willi.
Obese.
Thank you.
Angelman syndrome, right? Right. Again, so puppet-like gait, inappropriate personal way. Cleft palate, predominant nose, square nasal, hypothyroidism, ears, looking at here. Aortic arch anomalies. So what is it?
Hypocalcemia.
What? Aortic hypocalcemia, aortic arch.
The George?
The George.
Yeah, pericardial.
Yeah. Okay. Majority of 22, right? So remember they'll ask you that on the boards. Facial syndrome, right? Catch 22. So of course, they'll either give you the heart condition, so you got to worry about hypocalcemia. They'll give you this, put the George down, maybe hypocalcemia or cardiac lesions, that aortic arch defects, right? That's how they ask you 3 different ways. The question, all right? So you may put hypocalcemia in the lab results in the thing, and then give you the history, okay? Thymic hypoplasia, whether or not infections and things. So subvalvular aortic stenosis, prominent lips, high-stellate iris, mental deficiency, hypercalcemia.
Really?
Yeah. Large tongue. What is this? Right? Wilms. So Right. And this turns. Like they have a. So this would be Williams, right? Like the Guideman. And Turners, they get, you see some edema, right? 10 to 20% isolated from, it's just a guy going, we gotta work. They may give that in history, web neck, of course. I was doing the recertification thing, and that I have to do it just for CME now for credits, because I already did it already. So I had to do it last night with me. But one of the questions for this, for growth hormone, when would you give growth hormone to a girl with Turner's, right? When there was a weight, when there was a height drop off of started. You don't wait. It's not in terms of anything else. That was the answer. All right, that's it for this one.
Yeah, we'll finish exactly. 11:50. 11:59.
Thank you, Dr. Brown.
I know. I mean, whenever you wanna, it's up to you guys. I know you have the test on, whatever the test. We have, this was one. One is number 2, 3, and 4. So how many is here? How many slides?
224.
There's 224 in here, right? This is lung development, RDH, and all that. And then coherent voice right now. 3 has slides.
80.
80. That's nutrition. And then I think the other one was, the last one is cardiac. Cardiac, 90 slides, cardiac. So I think, let me know.
Okay.
Yeah, I think Monday we've got this right here. Doing neonatology.
He's back.
He comes for lectures.
Oh, he comes
But
in?
he's no, he's
After
doing super.
Quraishi or
He wants to come in person, he said, so he might.
because of course?
No,
He's gonna start coming in
Syracuse.
person, Syracuse?
Yeah.
After section?
Yeah.
He's getting break? Okay.
Thank you so much.
Thank you.
Thank you.
Thank you, Dr. Barone. Thank you.
All right.